Today we're having a session on optimizing transitions of care by Marilyn McDonald. Marilyn is an associate professor and an associate director of graduate studies in the School of Nursing, Faculty of Health Professions, Dalhousie University. Of course, she's our theme lead for transitions of care. She has a PhD in nursing from the University of San Diego and a Bachelor of Nursing from the University of New Brunswick. She's also served as a member of the Canadian Patient Safety Institute core team of researchers for safety in home care, and she's selected to be a member of the multidisciplinary group to establish the safety competencies enhancing patient safety across health professions. Her program of research is focused on safety in home care, and her research has contributed to mapping the terrain of safety in home care, recommending changes in home care delivery, and to setting priorities for research in this domain. At the end of this session, we will have an opportunity for people to ask questions. Please use your chat function or question function, and what we'll do is to try and get to all the questions at the end of the presentation. Future TVN webinars, Wednesday, or I guess I have still Wednesday, January 7th up there, but there'll be March 4th, April 1st, May 6th, and June 3rd, and you can register now, and we will have this up at the end of the session so that you can see which ones are the next upcoming webinars. So Marilyn, you can start your session, and thank you so much for agreeing to come on today. Okay.
Okay, thank you. It's my pleasure to welcome those of you who are listening in. It's a great, I was thrilled to see that this is one of the themes designated by TVN, because transitions in care are something that are important, I believe, are very important, and in particular to the elderly, which is very much the heart and soul of TVN. And hopefully after today's presentation, that for those of you who haven't thought a lot or read a lot about transitions, that your appreciation for that will be enhanced, and I expect we'll have an opportunity to learn from each other more about transitions as well. So just an overview of what I plan to cover in the next 30 or so minutes. Of course, beginning with a definition, some of the issues associated with transitions and patient safety, and of course patients and caregiver, and by that I mean their family caregiver perspective. And although time doesn't permit to cover all transitions in every context, certainly where the majority are covered, I will speak to individually. And of course transitions in relation to safety in home care, because as you know, that's where my research is focused. Initiatives related to improving transitions also will address some of the transitions projects that have benefited from TVN funding, and close with some barriers to transition programs. Oh, my screen is just my...
Sorry, Marilyn, are you on transitions defined slide?
That's where I was hoping to go to, but all of a sudden I don't have control of my screen.
Okay, I've got it on right now, so you can continue, and we'll try to change it as we go forward.
Okay. Okay, so you will notice throughout the presentation that the work of Coleman is certainly referenced heavily, and Coleman who's a geriatrician based out of the University of Colorado, has been doing work in this area since certainly the early 2000s, but from 2003 onward. I'm sorry, I'm not quite sure what's going on with the screen.
Change the
Okay.
presenter to you. We'll change the presenter to you and you accept.
Okay, I think I did that. So do I click? Do I just click show my screen?
Yes, please. As you know, Marilyn's not in the same building as we are, so there we go. You're on.
Okay. So that everyone participating has some sense of what I'm talking about with reference to transitions, I've used the Coleman definition. And the other statement that I believe is highly relevant with respect to transitions comes out of the work of Greta Cummings at the University of Alberta. And certainly what we want to strive for would be the successful transition, which of course would be considered safe, effective, and efficient. And so because TVN is very much focused on the elderly, just situate us with some figures around the numbers of people that we're looking at in this country, and I think this slide captures that reasonably well. And the bullet number 4 indicating that 1 in every 6 seniors receives home care, and in that I'm only referring to publicly funded home care, so the numbers of course would be considerably higher if we thought of the total number of individuals receiving home care, period. And so the other point that's not on this slide but that I would like to make is probably somewhere in the order of greater than 70% of referrals to home care originate in institutional settings. So we can certainly appreciate that there's considerable transition between hospitals to home care. And of course, our institutions, we know, are always, in particular hospitals, are always wanting to move patients through their system as efficiently as possible. And so timely discharge really calls for tremendous focus on preparation for that discharge. Now, in many instances, because the admissions of the elderly are not planned, then planning ahead can't necessarily happen. But for elderly who, for example, have planned surgeries, that creates a great opportunity to be able to do some pre-planning, to be able to transition them to wherever they were before the admission. And of course, for those in which pre-planning couldn't happen, then the amount of planning that will need to take place if they're hospitalized unexpectedly is considerably more. And of course, the costs for institutions or for anywhere in respect to caring for the elderly are certainly considerable. And also, hospitals do spend, that's where most of their budget, most of healthcare's budget goes to hospitals. And you'll see the nursing home rate, and of course I've indicated home care here. And certainly it's an area where most provinces are working harder to increase what they can offer in terms of home care, because naturally institutions want to transition individuals to home as quickly and efficiently as possible. And we do know from our research in home care that that's where people want to be, if at all possible. And note here that the spending in the home care sector by New Brunswick is at 6.3%, which it represents the highest investment in the country at this time. And so, of course, naturally moving patients out of hospital helps with the reduction in wait times, and we, on a daily basis, hear about individuals who are waiting for various procedures. And at the same time, wanting to provide patients with the best and most appropriate care in the most appropriate setting. And of course, in order to achieve these two goals, high-quality transitions are a must. And very important, the survey that was done by Schoen et al. In 2011, where they looked at hospital discharges in 11 countries, and findings that at least 1 in 4 patients received a lack of follow-up instructions. So this speaks directly to the gaps or the challenges and the work that we have to do with respect to transitions. And this point, in terms of patients and their caregivers, and in this presentation, when I use the term caregivers, I'm referring to family caregivers, and of course, not paid providers or paid caregivers. And over again in the literature, and of course it goes back to Coleman found this in his early work, and certainly in all the work that we have done in safety and home care, that patients and families tell us over and over again how they find themselves as actually having to figure out what needs to happen and coordinating services. And of course, when we're talking about the frail elderly, you can appreciate that the patient normally of course, is elderly, and the family caregiver is often a spouse. In that case, being an elderly individual as well. And they really do find the responsibility that they're charged with to be daunting. And of course, coupled with this is the likelihood that an elderly person will experience more care transitions, and that could be within the period of time. For example, if they're hospitalized, they may have several transfers within the hospital itself, transitioning from unit to unit. Or if, for example, or it could be, perhaps they can't return home and they require long-term care, so there would be a transition there. If it's nursing home, a transition there, and so on. And of course, when these transitions, excuse me, do not occur or are not well planned, then we end up with the exact opposite of what we hope for, and of course greater use of hospitals, emergency departments, and so on. And so thinking about why we have some breakdowns in the transition process, and I think it's always important to look at how care is organized, and it doesn't matter whether it's care delivery in an emergency department, in an institution, home care, it doesn't matter where. The way in which we have it organized is always a place to look at in terms of is it organized in such a way to facilitate efficient and effective transitions. And full knowledge of the care received wherever the person is coming from is essential, as well as transmission of that information to wherever the person is going to. When we think of breakdowns, for example, at the clinician level and PCPs, I'm referring to primary care providers, may well not be managing the treatment of for example, if a primary care physician admits an individual to hospital, depending on where that happens, the care may be organized and led by someone other than a family physician, so that when an individual is transitioned, for example, to hospital, from hospital to home or elsewhere, the physician may well not get the information necessary in order to be able to provide the follow-up that's required. And of course, the third point, the patients and their caregivers not getting the preparation they need to be able to carry out what's required once they're home. And this certainly it reminds me of a study that I completed just a couple of years ago. And I was actually looking at, it was a hospital-based study, and I was looking at the role of hospitalized patients with medication management, and all of the people involved in the study, of course, were elderly. And just in terms of the medication administration system within institutions is not really designed for a role of an individual or a family member. And yet, when the individual is discharged home, we expect them to be expert and to be able to manage their medications, take them as directed, and of course, when this doesn't happen, they may well end up being readmitted. And in many ways, when you think about it, we may be setting them up for this failure. Now, of course, in this study, patients themselves and the home care nurses and hospital nurses that I spoke with certainly could attest to the fact that many patients were too ill to be involved in the process. And as soon as they were slightly or deemed well enough to exit hospital, then that discharge happened ASAP, and yet the individuals didn't necessarily feel that they had the knowledge and information to be able to carry out their care as the healthcare providers would have intended them to do. And the other, these are further points that certainly we found out in our work. And the more service providers and settings involved, the challenges with respect to all aspects of care. And in some homes, for instance, an individual may be admitted to home care, and so, for example, meals are provided by one agency, personal care, help with personal care may be another agency, rehabilitative services may be another agency, and they may require nursing services as well. And so these could, into one household, you could have several agencies actually delivering the service, and no individual from any one of the agencies is clearly aware of what the other agencies are doing. And here again, patients and families end up feeling and carrying out the coordinating activities no matter how able they are to do it. And the medication errors, and I think that we often think, well, we have medication reconciliation, isn't that doing the job? And certainly when people, for example, if they go from home to hospital, medication reconciliation is carried out at that point, so that their medications that they are started out in hospital are reflective of what they've been on, and the same thing happens at exit. But once the patient is home and they've just had a hospitalization, in follow-up, it's not unlikely that there will continue to be medication changes, and so the ongoing reconciliation at points of transition, I believe we're doing reasonably well. But beyond that, the regular medication reviews that are required are not necessarily happening. And of course, one of the very key periods of time is in those 30 to 60 days following, whether it's to home care or particularly if it's to home care. If services aren't provided in a timely way, the likelihood of readmission is definitely considerably higher. And I noticed although I haven't referenced it here, some work by Coleman in 2010 when they were looking at post-hospitalization transitions, and they were examining the effects of timing of primary care provider follow-up, and actually found that rates of follow-up were 49%, 30-day readmission rate of 12%, And patients who didn't get timely follow-up were 10 times more likely to be readmitted. And so their conclusions from that study was that effective transitioning of care for vulnerable patients requires timely primary care follow-up. And I think we'd all have a hard time to argue with that. And of course, communication. We know communication is important no matter what the situation is, but certainly at points of transition, critical. And actually having the elements of knowing what's gone on with this individual and what the expectations are is critical to be able to provide the transition required, safe, effective, and efficient transition. And although I mentioned patient and caregiver perspectives earlier, because it's played such a central role in our work, I feel compelled to speak to it a little bit further. I've already said they feel unprepared for their role. One point that I haven't made was, and that came out of our work, we actually report that patients describe what we describe, use the term conscripted to care. And in many instances, they truly felt that when they were asked to take on care of an individual, they really, in most cases, they never or couldn't appreciate before being asked how much time and effort that would actually take. And and they didn't necessarily feel all that involved in the individual's care while they were still hospitalized. But certainly at the point of exit, they realized how they became the center of expectations around care provision, and without necessarily understanding what all that entailed. And of course, they're feeling trapped in a role. And also the strains that because depending on, in the frail elderly, by and large, the caregivers are going to be a spouse, but in many instances, it may not be a spouse, it could be a family member, and a family member who's still in the workforce. And so, of course, you can appreciate the strain, work-related strain that individuals will experience, and needing that income, so needing to continue to work, but also, and in many instances, of course, they'll end up purchasing additional services to help them out. So it can place financial strain on resources in order for them to be able to juggle the care of this individual and continue to work. And in many instances, these individuals, whether they're still in the workforce or not, experience considerable deterioration in their own health due to the amount of physical care that they need to provide, but there's also the emotional, social, and financial challenges that surround that. And so now I'm going to move to talk a little bit about transitions, points of transition that very commonly happen. And so the first one, no surprise to any of us, transitions from emergency department to home very commonly happen. But in terms of the way care is organized in ED departments, it may not be organized in such a way to be able to provide the information necessary. For example, if this is an individual who's already receiving home care, what's the process, and is there a process for that home care personnel are updated on that transition, and do patients and their families get the information that they need to be able to carry on. And of course, when frail seniors enter ED, the fact that they, by virtue of being a frail elderly person, they undergo more tests and have longer ED stays, and which of course results in the necessity for transmission of even more information because of what is the number of interventions, tests, and so forth that have gone on during that ED visit. And then, of course, in transitions from hospital to home, these Kripalani, this is American research that has been done. And certainly the whole medication piece is a very, when I think of the safety in home care study, and we looked at the adverse events in home care with a rate at somewhere around 13%. And number one in those adverse events was falls, but certainly number two was medications and medication related. And so certainly what people need to know, the knowledge they need to have, and the supports that need to be in place are considerable. And of course, once again, the importance of communication and also of written instruction. And I'll speak to that a little further when I get around to the place where we talk about some interventions related to transitions. And of course, transitions in the long-term care, from the long-term care setting. And when you think of long-term care, these individuals, whatever long-term care setting they're in, is actually considered their home. That's the way they see it. And typically a transition from wherever they are to hospital is very disruptive. And trying to adapt is not easy for this population. And I think probably the other point that I would highlight here is how important a comprehensive plan as well as the information required for wherever the individual is. For example, when they're coming from long-term care, the more information that hospitals and emergency departments can have, the better, and vice versa. When they're transitioning back to where they normally live, the more comprehensive the information. And because individuals who they have a daily routine, and when those daily routines are interrupted, really their level of function can decline quite severely. And so it's important to keep their level of function at maximum at all times. And transitions are a real area of risk in terms of them possibly losing the function ability that they currently have. And of course, long-term care and emergency departments. And the whole notion of avoiding visits to ED is so important. And I know there's initiatives afoot across the country. And Carol and I had the opportunity to dialogue a little bit before the webinar started today. And she was telling me that she had heard about the initiative in Nova Scotia, where instead of, to a great extent possible, trying to assess elderly individuals at their in-home or at a long-term care facility or elsewhere to try and avoid having that transition to an ED department, if at all possible. Now, certainly the assessment, perhaps through the assessment, it will be deemed that they actually do need to go to the emergency department. But deploying individuals who can actually do those assessments where the elderly person is certainly one initiative that can cut down on the number of transitions that happen. And although it would be nice to think that every individual responsible for care for an individual, for example, in long-term care, would be able to carry out and provide the information required during any transition. That's not always, it certainly is not the case. However, certainly trying to have designated persons to make sure that the information provided information needed at the time of transition is provided to the receiving destination is so important. And just that third bullet, it certainly is, when you look at 85% of transfers having informational gaps. Certainly speaks to the importance of this being one of the theme areas for TVN. And of course, transition from hospital to nursing home and back. And in a lot of instances, when transitions, of course, if they could be planned, likely we wouldn't have nearly the information gaps that we see. But in many instances, that just can't be. So it becomes certainly increasingly important that we actually have initiatives in place to be able to make transitions as smooth as possible. And again, once again, we see this patient's lack of information and how disruptive that can be. And as I said just a few moments ago, it can lead to a decline in their conditions, which whether it's long-term care, no matter whether it's they're at home, that's the last thing we want to happen. Certainly now I'm gradually going to get to some of the important work that's going on with transitions. And this work done in Alberta, this older person's transition in care, the OPTIC study, where they pilot tested a transition tracking tool. And these things this was a Partnership for Health Systems Improvement grant from CIHR. And as you can see, certainly when they piloted this, the amount of information that they gathered for this tracking tool was really considerable. As you can see, some of the items, resident characteristics, their reasons for transfer, and so on and so on, and the amount of time to complete the tracking tool. And I suspect, and certainly the amount of time is trying to get your hands on the information you need for that transition when you need it is a challenge in our systems as well. They also found an information gap in documentation shared between facilities, and also that nursing home residents were at risk for errors and adverse outcomes. So important work here at home. And then in terms of care transitions, and most of you probably realize that between 2010 and 2012, the first ever Pan-Canadian Safety and Home Care Study was completed. And certainly, as was alluded to earlier, the importance of the first 30 days post-hospital discharge as being a very high-risk period for the home care client. And of course, many of the risk factors that we identified were certainly identified in other studies, and that being the number of medications individuals were on, where their ability with respect to activities of daily living, and of course the number of comorbidities they had and the particular diseases they may have been affected by. And also that many of these adverse events could have been prevented if high-risk clients were identified and effectively transitioned. So even though, for example, in this work, these studies weren't devoted towards the notion of transitions, as you can see, this has certainly come out of the work. And several more points here with the importance of integrated interdisciplinary healthcare teams. And although we know this is important to do, and we're working on it in many sectors and many areas, we certainly do need to continue to work and make sure that we're providing interdisciplinary integrated care for individuals, particularly the elderly who are frail. And again, these other two bullets I've actually addressed in previous slides. And so in terms of improving care transitions, these doing this sort of things, transition programs, certainly do exist and are known to reduce or delay admissions to nursing homes. Having access to publicly funded and community-based services keep people at home longer. All jurisdictions know this and are all working towards this goal. And of course, by working in bullet 2 areas, certainly the likelihood of institutionalization can be, certainly the timing for institutionalization can be delayed, which is a transition that is favored by all, not only healthcare providers, but also families and patients. Certainly the communication that's been mentioned by all can't be emphasized enough. The preparation of patients and caregivers for what to expect. However we can help individuals, in addition to medication reconciliation that now exists, we do need to take this further as well. And of course, patient involvement. And Coleman, in his work well more than a decade ago, was very clear that the level of involvement of patients and caregivers had to be front and central to make transitions work. And so for those, as many of you listening in may know, and certainly there are a number of TVN supported initiatives underway. I haven't listed them all here, but for example, bullet 1, the development and testing of a standardized communication form to improve transitions for nursing home residents. As you can see, based on what's been presented to date, how important this work is. And then at Waterloo, choosing healthcare options by involving Canada's elderly. And of course, what this team is in their synthesis of the knowledge, what they're actually going to come up with, okay, what are the best ways, how can we help the elderly choose options in terms of their care. And of course, the more we involve them and their families, the better, instead of us deciding we think we know best, if they're involved in the process, the likelihood of whatever the plan is, although it may take more time to get there, in the long run will be more successful. And then of course the shared decision making with the elderly related to remaining at home or moving to long-term care, and that's Lagare at Laval. Again, important work. Now there are several projects that I haven't mentioned here, but one of them is McGilton at University Health Network in Toronto, or Toronto Rehab, whereby in terms of a rehab program focused for people in their homes to be able to maintain and improve their function. Again, is another important initiative supported by TVN. And so, you know, if you're wondering, well, okay, what kind of transition care programs are out there? And as you can see, Coleman, again, actually out of his research, developed what he called the care transition intervention. And really, the basis of this was to provide patients and caregivers with tools to encourage them to actively participate in the transition from hospital to home. And some of the areas that were focused on in terms of making this program work: medication self-management. From what was previously presented, you can see where that would make sense. The patient-centered record, and of course whereby you have a record that's accurate, up to date at all times. And of course, primary care and specialist follow-up. And as I mentioned earlier, the importance of effective transitioning, having that primary care follow-up in a timely manner. And actually, I noticed recently, I believe it was in 2012 or 13, that Coleman actually had did all this work around transitions between probably 2003 and 2006, and really has been working diligently to try and have uptake and adoption of this care transition intervention, and I noticed fairly recently that a dozen or more agencies and institutions in California received funding, and they're actually instituting this care transition intervention of Coleman. And of course, these are again from the literature, which is well over a decade old now, where a number of institutions used advanced practice nurses, which could either, of course, be clinical nurse specialists or nurse practitioners. And of course, the idea was for them to work in collaboration with patients, with the physician and families to be able to transition patients safely and effectively to home. And of course, you can see here visits within 48 hours, at least 2 home visits, and weekly telephone contact. So again, you can see this assisting individuals with knowing what they need to do and giving them the support in that time frame immediately after being discharged. And some of the results achieved there. The other probably more recent program that all of us, and it's become rather disease specific, and when you think of it in terms of the Navigators program, probably the first thing we think of is cancer related navigators for people living with cancer. But certainly there's no reason not to think that the same principle could work nicely for the frail elderly. And so with this, it's probably not great to close with barriers, but there's certainly, we know that, so if we know all of this, then why aren't things happening in a timely manner? And so I do think that we need to look at how we deliver care, both in institutions, that being acute care and long-term care, as well as home and continuing care. And are there structures and processes in place that facilitate transitions? And I think we probably will find that there's improvements that we could make. And again, when we work interprofessionally and in teams and provide integrated care for individuals, I believe these approaches can contribute to, when we don't have this type of model, certainly can lead to barriers in transitioning. And as long as we remain downstream oriented, that is, instead of keeping individuals from ever getting, for example, to the institution door or being able to manage them at home, is certainly much more upstream in our thinking rather than downstream once something happens. The rates of investment in home care, as I said earlier, all jurisdictions are working at increasing the dollars that go in this direction, and I believe that they'll continue to do that, and we'll definitely get results by doing that. And of course, I think we have to be creative in terms of thinking about barriers, because if we're thinking of going the route of instituting new roles, that always, of course, means adding dollars, creating positions and adding dollars. And so are there systems and processes that we can put in place in existing systems? I think we probably, if we put our creativity hats on, could come up with ways and means that we could work within existing structures to be able to transition individuals much more effectively than what we're doing now. So thank you for your attention, and I'm happy to take questions and comments.
Okay, Marilyn, thank you very much for your presentation. It was both informative and comprehensive, but we still have a few questions.
Okay.
The first one is there a greater role for volunteers to help in community care settings to reduce caregiver burden?
Yes, actually, I definitely think there is. And I can think of an initiative actually here in my home province in Nova Scotia. In one of our counties, we actually have an initiative underway, and of course the community, they were able to get some provincial government funding for a coordinator, and what this coordinator has done is rallied a group of volunteers, and they actually go into individuals' homes, and they've instructed, for example, the person, the client or the patient in that home, they've instructed them in a number of activities that help the individual maintain their current function and hopefully even improve the function that they have. And with the whole notion, of course, if whatever mobility they have can be maintained or improved, they get to stay there longer. If their mobility can be maintained or improved, the effort required by whoever they're living with to help with them is stabilized and may even be reduced. So it's definitely, yes, the answer to the individual's question is there are initiatives, and I think we can certainly expand, I know we can expand those initiatives within our own province, and I'm sure other provinces are doing likewise. I think of the SMILE program that VON coordinates and offers, which is not exactly what I just described, but in that vein. Now, they haven't evaluated that program, but I believe are planning to do so in the future. And so I really appreciate that question, because I think there's lots that we can do.
Yeah, I think there is too. Another question is, and you spoke about the coordination of information between all the individuals involved in the care. It would seem that the electronic records in all the provinces, like being in all the provinces across all care settings, would improve the coordination of care. And I guess the question is, do you know if it is still just the privacy information that is holding up this implementation?
I think privacy could be a factor, but I believe the interface with respect to information systems across facilities is still a challenge. So in other words, if the information systems can't talk to one another between a hospital and a home care setting or a nursing home setting and so on and so forth, that I believe that continues to be a challenge.
Yes, I think so too. And another question, and it's kind of a two-part, it was about the Nova Scotia paramedic study, or I guess it's actually in practice in Nova Scotia and maybe even in the Halifax area. When I was at QELCCC this weekend, they had talked about putting it in place in Alberta as well and modeling that study based on the Nova Scotia experience. So the question is do you know much about it, and can you explain what it is that they're actually doing?
Well, it would be emergency health personnel, for example. I haven't, I guess to answer how much do I know about it, I know that the program exists in terms of exactly the mechanics of its functioning. I can't give you the exact details on it, but I could certainly get that information and provide it to you, Carol, so that it could be disseminated to individuals who are participating in the webinar today, because it certainly sounds like it may be helpful to have some details, because I stayed very generic in terms of an emergency health service member going to an individual's home, doing an assessment and making a decision about whether they needed to be transported or not. And so I can see where that could lead to a whole series of questions in terms of, so, how does that call get made and all this sort of thing. So I don't feel that I can give you the exact details on that at the moment, but I would be very happy to get those and to provide them.
Okay. I think I have one last question. It's from a nursing PhD student. She said she's done some research in the area and she's concerned that mentioned interventions do not target people at greater risk of rehospitalization, people with dementia. What are your thoughts on this gap in research and practice?
So I'm not sure I understand the question.
Okay, so she says, I am concerned that the mentioned interventions do not target people at greater risk of rehospitalization, and basically talking about those with dementia. So,
yeah, certainly the dementia population, that adds yet another level of complexity, there's no doubt about it. And individuals, spouses who are trying to look after an individual with dementia, the level of support and the nature of support in order to be able to continue at home is significant, and would require, when I think of if you were trying to transition, first of all, trying to maintain someone at home, the nature and level of service would be considerable in terms of, because very often the individual with dementia, whoever's caring for them, it may be around the clock happening, so that of course the fatigue factor for whoever the family caregiver is incredible. And so the level of service that you would need to provide so that that person can sleep at some point during that 24-hour period. So certainly I didn't get into those details, and that is in situations where the home care client has dementia, definitely the assessment of the needs there and what would the plan that would need to be put in place. I appreciate that certainly what I've said didn't address that directly by any means, but do realize that that would be a very challenging situation. And not that it can't be done, but certainly it's really those plans would have to be very individualized based on the support system in place, and what services could be provided to shore up that support and make that situation doable.
Okay, Marilyn, we are near the end of our time, so I'd like to thank you and everyone who joined us today. Please visit our website for future monthly webinars, and please do not hesitate to give us some ideas of topics that you would like to see in the future. Our PowerPoints and webinar will be on our website either later today or tomorrow if you want to review them at some point in time. And thank you very much. That's it for today.